And next, I would like to invite the other Korean colleagues. He's one of the one as well. Professor Jin Kim from Baidu Hospital. He will talk about the sharp recognition of chronic central venous occlusion in dysfunction hemodialysis fistula. Please.
Thank you for the introduction. And I would like to thank Dr. Whan and the organizers of VSIR for their warm invitation. The previous speakers, Dr. Whan and Dr. Jackie, have made things easier for me because they've kind of explained all the techniques that are used to reconnect the central vein. So I will eventually go through some cases which are pretty much similar using the various needles and the devices that we have. Just to recap on central venous disease, the incidence has been reported to be as high as 40%, but this is actually an increase in the increased prevalence of patients undergoing hemodialysis. The pathogenesis could be related to long-term catheter placement and also due to the fistula because it causes hemodynamic changes in the central vein. In patients who are not undergoing dialysis, these may be asymptomatic, but in patients who have a fistula and the ipsilateral arm, the patient could eventually develop a swelling and also have dysfunctions in the fistula. And this is a typical example of a patient with a catheter-related central venous occlusion. You can see in the second image that even with the removal of the catheter, you can still see the occlusion. So eventually, we performed an angioplasty in this patient because the patient also had a fistula in the left arm. And this is a typical case of a patient with fistula-related occlusion in the subclavian vein. And you can see his right arm and shoulder is severely swollen, and there are also collaterals, and we did a angioplasty in this patient to save the fistula. So the Kadoki guidelines, as you know, recommend angioplasty as the first line treatment, and it's rewarding because it promises a very high success rate, even higher with stents. But we all know the patency of central venous procedures need a little more work to be done to ensure we get better patency, because it's still an area that we don't really have the answer to. This is a patient that we stented. Again, get higher technical success rates with stents, but these are always problematic later on because we have atrial hyperplasia, which eventually cause narrowing and occlusion of the stents, and we have to do repeated angioplasties over and over again. So the cases of the central venous stenting that I just presented were the cases where we could increase the chances of technical success by placing stents. Another way we could increase we can also increase the patency and improve the patency of these stents by using cover stents. This is actually a Korean cover stent, but due to the availability of such covered large stents, I think there's a limit to how much we can use in different regions. But there's still lack of data with regards to the patency of cover stents. So as we know, it's better, but so I'm still surprised that there are very little data to show apart from case series that include only like 20-30 patients per studies. But anyway, we probably would get better patency with the use of cover stents. And also cover stents you can always have on the shelf and be reassured, because anytime you get kind of angioplasty-related bleeding, then we can be safe in the hands of these cover stents. Another way we can overcome technical failure is when we actually have the wire across, but we have difficulty in having crossing devices through the occlusion, whether it's just catheters or blue catheters. This is a typical case. This patient had a right-sided pump cath and a fistula on the left side. The arrow shows a collateral connecting the two sides, and the actual numbing vein would go through along the path of the dotted line. And we're just using typical full French directional catheters and the durable hydrophilic guide wire to find our way, which wasn't successful. So we eventually changed to an 014 system, which surprisingly just went through quite well. because of port support, we also did the femoral access to get a through access. And then because we already had a Go 14 system, we started working with small profile orthotic balloons to upsize to larger balloons, and we eventually stented this patient. So coming to the main theme of this presentation is when we have difficulty in crossing the guide wire or across central venous occlusions. And as I showed you in the previous case, we can try and use other catheters, lower profile balloons and wires. But when this is all unsuccessful, then we have to try other tricks up our sleeve. And considering that up to 24% of all failures come from failure to cross these lesions, it's nice to have some other alternatives to reassure success in these procedures. And these are a few of the techniques that have been described in the literature. And the first one is, I think Dr. Hwan also showed this in peripheral artery intervention, is using the back end of the terminal or other hydrophilic guide wire. So the normal standard Bull 35 guide wire, you flip it over to the other side and use the hard end. And this is an example of a case, 66-year-old male, and as you can see, this is the normal end of the guide wire. You can see it's buckling and kinking. So we also tried the femoral route. You can see 7 French sheath in the SVC, and again that was unsuccessful. So we went back in from the top, and we used the stiff end of the guide wire, which penetrated the hard lesion. From there on, we changed the wire to the soft side again and brought it down to the level of the IVC to get good support, and did our typical angioplasty procedure. So this is probably the most cost-effective and easy procedure to do, except that it doesn't work all the time because depending on the direction, the wire might not be facing the direction that you want it to, and there's pretty poor directional control with these techniques. The second technique that's been described is the use of the tuber needle, and we previously talked about the flyover technique. It's similar, but we cannot use this on the ultrasound in the central vein. But the case I have here is actually not the central venous system, but it's actually just past the around the level of the cephalic arch, where it joins the subclavian vein. And you can see this vein has a completely obliterated outflow vessel. And we tried canalizing from antebrain and also through the jugular vein, and this was unsuccessful. So we studied the image carefully and thought we might do angioplasty of one of these collaterals and probably be able to end up in one of these perforating blood vessels over here. So this is what we did. And then we used low-profile balloons to do a kind of a balloon assisted maturation procedure for the outflow, and after we did a few angioplasties, this is the result we got. We did more angioplasties. You can see how the pulse rate is actually going in the wrong direction, but this is the only thing we could work with. So we did repeated angioplasties, and we were satisfied with this result. We intentionally decided to bring the patient back after 1 month. Unfortunately, we closed off again. So we then tried with 4 French catheters and different wires to get through, but this time we couldn't get through because this wasn't a straight course. So going back to the technique that Professor Jackie showed us, we used an ultrasound. I unfortunately don't have the ultrasound image, but this is an area, a segment where we can actually scan with the ultrasound because it's not too central. And we used a 21 gauge and used a 018 a wire to pass into the central vein. This is the 21 gauge tuber needle, and this is the 018 guide wire, and then we worked with balloons. And again, in these segments, as mentioned previously, we like to place stents. So this was a Covera color stent, which we placed and kind of made a straight pathway into the central vein. And this is the initial image, and this is the final result in this patient. And this patient is still, still working well. Third technique is the use of the septoplasty needle, and as interventional radiologists, we are used to the use of TIPS needles, and this has been reported quite a long time ago, in 2005. This was a simple case of a central venous occlusion, which was treated with the aid of the TIPS needle. And in 2010, there was a case series of 33 patients from Korea, And this time they used a rouge needle, which is smaller in profile compared to the gold pinto needle against the tips needle, and they reported a technical success rate of up to 94% and no major complications. So this is our case. You can see we're just trying everything here. There's a occlusion here, and then we came into the fistula, again using a full French catheter and all the wires that we can use. And you can see in this image, we've also tried from the femoral, but it's a straight course. The femoral goes straight up to the jugular, and we want to come to the side. So again, we tried from the fistula side, and this is the backhand of the terminal guide wire. And it wasn't really penetrating the vessel until you realize that the target is actually anterior to where the fistula side wire is. So in this case, we need some kind of directional control so that the needle would face forward. So the tips needle in this case is quite useful because it already has a bend. So this is a sheath from the femoral side, and this is the needle from the fistula side. And please note the needle is actually pointing anterior, and this is a very important point that I'll come back to in the next slide. So you can turn the C-arm around more lateral, and you can make sure that the needle is coming anterior towards the sheath. And at this point, if you push a little forward, you can see the sheath moving, so it means you're against the sheath. And then you can do a jabbing motion to penetrate this septum and pass the guide wire and do your typical angioplasty procedures. So, as I mentioned earlier, you have to be facing forward because if you look at this schematic diagram, the subclavian vein is actually situated anterior to the subclavian artery and the brachial plexus. So as long as you're going anterior, which is the normal anatomy, then we have no risk of arterial bleeding or brachial plexus injury. So as long as we know this anatomy, we can be more reassured that we're not going to have any complications. Of course, you can use safety measures like having a sheath on the other side of the occlusion through the femoral axis. You can also use balloons, like in this diagram, to use as a target. The last one is the re-entry device, and this was also shown in the slides presented by Dr. Hwan. Surprisingly, there are not many reports in the literature on this. The first one was from Singapore, and they reported, I think, 1 or 2 cases of successful treatment using the re-entry catheter. And this is our case. Again, we can use this for short segment occlusions, and when we try everything, try from the fistula side and try from the femoral side, and we cannot go across the occlusion, then we can push with the wire and go as close as possible to the other side. And this, a lot of the times, may be in what we call the sublingual space. And because the needle for the outbound catheter is facing towards the lateral position, you can then direct the direction of the needle towards the target area and deploy the needle. And this is a typical example of such a case. Of course, again, you can use a target. We are working from the fistula side, and we also have a catheter and wire from the femoral side. And from the femoral side, we place the balloon. And from the fistula side, we brought an outback catheter. And a lot of times we think that we're going to rupture the balloon, but this is such a wide space. I think, in my experience, the balloon doesn't rupture most of the time. It actually just pushed back, and the needle scrapes the surface of the balloon. So this is what happens all the time. But anyway, you can pass the balloon along the surface, pass the wire along the surface of the balloon. And then, because this is an O14 system, we first have to dilate the re-entry, the needle point with the O14 balloon and upsize with a O35 balloon and do the typical procedure. Sometimes the angles can be unfavorable for any kind of sharp recanalization technique. So, like in this case, we try to work over this angulation, but it's very difficult. So we pick to access this external jugular vein and come down from there. And this is how we overcome the unfavorable angulation that we may encounter in these kind of procedures. This data was actually, we presented this in many conferences back in 2000, around 18, 19, I can't remember. This is around 11 cases. We have done more cases since then. But going back to these cases, we only had one failure out of 11 cases. So I think the Outback device is quite a reliable device that we can use in central venous occlusions, and we didn't have any complications for this. So in conclusion, guideline navigation through central venous occlusions may occasionally be technically challenging, and we can overcome this with the use of sharp cannulation techniques. We have the, you can use radio frequency wires depending on which part of the world you're in. In Korea, we don't have radio frequency wires, so this is why you have to make use of all the wires and needles that we have off the shelf. So, like in the previous cases I showed you, I think the easiest one we can start with is using the back end of the guide wire, and then we can probably move on to using tips needles or other types of needles when these will fail. Thank you for your attention.